All right. Special guest star now joins us. My American public media colleague, Angela Davis. The incomparable Angela
APM
Davis.
cousin.
Yeah, we're cousins. We're cousins. We're absolute cousins. You know her as the host of MPR News with Angela Davis, weekdays at 9 o'clock. You were so generous with me not too long ago. As Neil mentioned, I was on your show, and I wanted to talk about economic inequality, which is one of my topics. Mm-hmm. But your listeners pointed out, right, that you can't talk about inequality without getting at some of the issues that we're discussing here on the stage, that it's part and parcel of this equity issue in America. Angela came to public radio after 25 years anchoring and reporting for television. You may know her from that capacity. Tell me, Angela, when Neil, my boss here, said that we're not foisting this topic on this session, but it kind of percolated up from the grassroots. You've seen it, even not just the day that you and I were on the air together?
Oh, yes. The talk show that I host, many of you may know, we are able to open the phone lines and take phone calls live while we're on the air from our listeners. And ever since the pandemic, people have just been openly sharing their emotions and their pain. And so when the producers and I, we've done many shows over the last few years about economic turmoil and personal finance. And we had done a show about college loan forgiveness. And we'd asked people, they've paused the payments, so what are you doing with that money? And they called in and shared all these stories about, we're paying off credit card debt, we are saving monies to buy a house. And so afterwards, when we were talking about that show, one of the producers said, we should do a show about medical debt. The church that she belongs to had just done a fundraiser for RIP, medical debt. And I was like, what is that?
Yeah.
And so when we did this show, Allison was a guest, and I was just shocked by how much pain people are in, and also the shame and guilt that came along with the medical debt. Because think about it. I mean, the reason you have medical debt is that you're in pain, right? You fell, you have a disease, you had to have a surgery, and you're going through all of this the strife. And then so many people don't have savings to fall on to help with an unexpected expense. And also it's like adding insult to injury. It's being kicked while you're down. So now you have all of these bills coming in and no way of keeping up and paying for them. And so the phone lines were full and people shared stories about, I was just living my life. I didn't do anything wrong. And now I have this additional burden. And I was surprised, and Allison, you may remember this, one of the first phone calls we got from a listener, he had $5,000 in medical debt that he'd been trying to pay off for 6 years. Mm-hmm. For 6 years. Yeah. And why is that? Because, he has limited means to do it. Another woman called in, you think about the reasons why people have medical debt. She'd been the victim of a violent assault. And in that assault, had suffered a brain injury and also damage to her visual cortex, so she couldn't see very well. So she was describing, I'm getting all these bills, but I have short-term memory issues now because of the assault. I don't understand the bills. I don't even know how to call to get help. I don't know what to do. So it's just another example of just the despair that people have and how they're suffering in silence because they don't know what to do or how to approach something. It just doesn't make any sense.
That's the thing about when you do a call-in show, or in my case, when I go out in the field and I actually talk to people and hear the stories, you realize it's not a PowerPoint presentation, it's not abstract statistics. Let's actually play one of the callers to Angela's show. Just you can hear it in the voice.
I live in a house that is not mine. It would be, save for $28,000 in debt that my partner owed when she left this world. She had cancer. I myself am disabled, and there's this debt against this house. I'm unable, now I'm running out of cash of my own, but there's not even any way I can sell the house because it's not mine. I don't know what to do.
I don't really know what to do, he says at the end. I mean, people are in
Complete despair.
terrible despair.
Right. And Allison, as a guest, you also pointed out to us, we talk a lot about racial disparities in Minnesota on my talk show, the racial dynamic to this, that people of color, communities of color are hit harder by medical debt. You shared a statistic. You said in Minnesota, when you look at medical debt, 12% of white Minnesotans are dealing with it compared to 29% of people of color with medical debt. And that, this needs to be fixed fundamentally, and the burden shouldn't fall on the patient. I don't know. Right after I did that talk show, that was in July of 2022. I shared with you guys backstage. I fell in August of 2022. I tripped on a sidewalk and shattered 2 bones in my elbow. Had to have emergency surgery, ambulance ride. I was out of town. I was in D.C. And months later got the bill, and it was a $25,000 fall. From the ambulance ride to the drugs to the surgery, and fortunately I have insurance, good insurance, and but I was shocked, and I kept thinking, I'm like, if I didn't have insurance that covered this, I have 2 kids in college also, like how devastating that would have been, and I'm still in pain, at the time. And so I just appreciate the work that Marketplace is doing to provide financial literacy to people who need ideas and encouragement, and the opportunity that I have to let people, openly talk about things that they are embarrassed about or that they don't understand.
Jennifer, I always wrestle with this because during open enrollment, that's the time you can pick, if you're lucky enough to work for a firm that offers employer-sponsored health care, but also through Obamacare, there's open enrollment. There are often high deductible plans offered along the ones that may cost more per month. And I know that not you, but people in your line of work used to love the high deductibles because they said, I used to report on this, that with skin in the game, if we're paying a lot of money up front, we will use medical care more prudently. Now, I'm not sure how Angela could have used medical care more prudently if she had a terribly broken arm. But what's your sense of this idea that these higher deductible plans bring some discipline to the spending?
Well, one, economists aren't always right. They don't always get it right.
No way.
It's based on the notion that, people don't like to go to the hospital or the clinic. So this idea that economists say, there's moral hazard, that if you don't have to pay anything out of pocket, you're going to want to go to the doctor all the time or the hospital. That's just not true. And, there was a seminal paper on there, but they tried, economists said, well, let's fix on the provider supply side and try to rein it in. Didn't work. Well, now let's look at the demand side. And if there's more cost sharing, they won't go to the doctor as often. But I just never bought into that. And it's not working. It's actually preventing people, when they have a lot of cost sharing, out-of-pocket payments, from getting the care that they actually need. So we have to go back to the provider supply side and figure out how to lower costs. But we should not put up barriers that prevent people from getting the necessary care because of the cost or the high prices. So yes, it was an idea that's still out there that is slowly being debunked.
Interesting.
Mm-hmm. Well, yeah, so I just want to add that, it was interesting. You mentioned earlier about the mortgage crisis, right? And what happened there was that we're giving out mortgages to people that we clearly knew couldn't afford them. Yet we're giving out health insurance to people with deductibles that we know they can't afford. And we're doing that. I mean, that someone doesn't have $5,000 to pay in their savings and will not get to that gentleman that you talked about earlier. He didn't have $5,000. That's why it took him so many years. Yet we let him have an insurance plan that requires him to pay $5,000. Why can't we figure that out?
But maybe some people here have faced this. Sometimes an employee feels that the premiums are too expensive, and so the high deductible plan seems attractive because nothing bad will ever happen to the employee.
That's true, but then that it's to the point of we need better subsidies then for these plans so that people can get access to plans that actually meet their means. There's a huge misalignment between what people are expected to pay out of pocket and what they can actually pay out of pocket, and that's where we end up with this medical debt.
Well, we focus so much on how much does insurance cost. Well, it's costing a lot more because our medical prices are high. So we have to get at the root problem, which is medical prices. And our deductibles are high because, people can't afford the annual premium. And so the premium is down, it goes down when deductibles go higher. It's just, it's so much, it's such a high percentage of people's paychecks now that we're in serious trouble because now people can't pay for food, for rent. They can't pay their basic necessities because their health insurance premium and deductible is so high.
And some of our listeners also described being worried about their credit rating because, the medical debt appearing or becoming part of their records, and then it just creates more problems. Again, feeling like they're, being kicked when they're already down. When all they did is walked out of their house, or, maybe they were in an accident or genetically, predisposed to have some disease. And again, they're already in pain.
Now, people here in the room also kindly submitted questions to us to bounce off the panel for us to chew on. I think Rebecca's here. Rebecca? Rebecca, you're live.
Hi.
Hi.
Thank you. My question was, instead of focusing on the debt, which is a horrible problem, and I think you all agree shouldn't be there in the first place, why aren't we investing into investigating universal single-payer health care? The administrative costs for insurance companies are astronomical. So it's not only the provider side, but the insurance for profit as well. So that's my question.
So as it happens, I've seen also some of the Zoom questions that have come in, and you're not alone, Rebecca, in asking about what about single payer? I'm going to start with the healthcare economist. Some thoughts about how to frame our thinking about single payer?
Well, on paper, it makes a lot of sense that we put everybody into the same pool and we average out the costs among everybody, and that should lower our costs for everybody. On paper, that's ideal, but even if we have single payer, it would also give us the ability to negotiate reasonable reimbursements to providers. It would give more control to improve health outcomes and quality. So I think it would be a simpler system if we had single payer, and it would have a lot of advantages. Politically, you saw what happened with the Affordable Care Act. Politically, it's very difficult to get there. Now, I think there are a lot more young people that get it. And it's just, I've been taught incremental policy reform. But big things can happen, like when we passed Medicare and Medicaid, when we passed the Affordable Care Act, and we just need to get everyone behind moving to something better. And when everyone is hurting because of high prices, I think I'm optimistic we'll do it in my lifetime.
But I want to ask about single payer because it's a good slogan, but one of the devil in the details pieces of it is it means some procedures will be considered essential and will be covered by the government, but not everything. And so that becomes, I think, Jennifer, a big public policy debate. For instance, Ozempic, would that be under the single payer, or would that be you got to pay somehow more out of pocket for that?
Well, I think we can negotiate prices with the drugs under a single payer, just like the VA system. And we see they get a lot more reasonable prices. So I think we would have more power to negotiate that. And some states like California are working on that. Purchasing power will drive those prices down when we can negotiate those prices. But people have different ideas, and there's a lot of myths out there what single payer actually is. It doesn't mean that government owns all of our providers or hospitals. It just means that we're all in the same insurance pool, and we have more leverage that way. It doesn't have to be, it's not government-owned, operated facilities. It's just that it could even be a third party that's the single payer. It's just that we're all in the same risk pool. That's what's important.
Allison, any thoughts about that?
Yeah, I mean, I agree. The politics are really, I think, a problem. And I think you have to really be thoughtful about how you're going to get from what we have today to that new place. It does mean like a fair amount of dismantling of what we have right now, which means different like jobs don't exist. And I think that's possible, but you do need to have sort of the meeting of the minds in terms of actually getting that kind of big shift in policy change actually implemented. And I am with you. I think, in the meantime, let's focus on some of the more incremental changes that can actually prevent people from being caught in the middle of this tug of war that's going on between the insurance companies and the healthcare providers about the price and who pays it. And increasingly, it's this patient that gets caught up in the middle and is ashamed and feels, but the system's really set up against those patients. So I'm always focused on those changes. How can we reduce the impact on the people who are trying to get the health care in the first place? But I think we need to keep talking at the same time about bigger vision for where we're going to go and how are we going to get there.
But I think, in my health econ class to my undergraduates, it's because every dollar we spend on healthcare is someone else's income. And there are a lot of expensive lobbyists who have a lot of power that prevent things from happening politically. So what we actually need, this is not related to medical debt, we need campaign finance reform.
Yes.
So those lobbyists don't have so much power. That's how we can get to a single payer, more rational way to pay for health care.
I just remember Allison gave me a visual that has really stuck with me in the 2 years since I did that show. You talked about people sitting in cars in the parking lot of emergency rooms, outside of emergency doors of hospitals, debating whether or not they should go in to get medical care.
Seeing if that pain subsides.
Right. You talk about that tug of war, and I just think in this country we can do better than that.
I think Diane here has a question. Hi, Diane, and the microphone's coming up from right behind you from my colleague. Hi, Diane.
Hi. I have been in healthcare for about 46 years, and I ran a free clinic for 10. And I'm wondering, can we get the same rate for care for the uninsured that the insured have?
And since so many people are insured, could we get the same rate for the underinsured? I guess would be a corollary to that. How do we think about an answer to that question?
The U.S. is very unique in that everyone faces different prices depending on how they're covered. It makes no sense. We need to reform that. So in Minnesota, I believe that this is in the AG's office, but if you make less than $125,000 and you're uninsured, you will not pay more than what a private payer would pay. Why is it only for people that make under $125,000 in income? I don't know. But we have to change that system that we're paying the same prices, because it makes no sense that just because you have Blue Cross and I have United Health Group or Medica, that we pay different prices. Mm-hmm. What's happening is insurance companies, they used to have the ability to negotiate lower reimbursement, so that means lower premiums for us. But because of the consolidation on the provider hospital healthcare side, they don't have much negotiating power anymore with these huge healthcare provider systems. And so that's why we're seeing this huge escalation in premium costs as well.
When you mentioned that every dollar saved, it comes out of somebody's pocket, that's a perennial interest on Marketplace. This notion that we measure the economy through gross domestic product, which doesn't have any values attached to it. It's money changing hands, good or bad. So often a really big hurricane is awesome for the economy because it generates the mayhem generates activity for contractors. And I once did a film that had a pretty good Minnesota State Fair scene in it. It was called Fixing the Future. It's about new ways to think about the economy. But in it, we had a cartoon about a really bad thing for GDP would be if I bought a locally grown apple and had that for lunch. A much better afternoon for GDP would be to drive to Whole Foods far, burn some fossil fuel, put some CO2 into the atmosphere, to buy a kiwi that came in from halfway around the world, but also to perhaps crash my car on the way to Whole Foods, because then there would be more economic activity. And so the argument is we have mouths to feed. We need to generate economic activity no matter what. There are experts smarter than me that think that should be cause for some reflection, I think. This notion of billing expert, coding, and not even being able to decipher what it is that you're getting. Or I think Minnesota, the proposed law in its early version was going to stop Minnesotans from being penalized if the coding was wrong. And they probably don't even speak the coding language to know it was wrong. Could this system be a whole lot clearer, Allison?
I think so. I also have some sympathy for, again, I think I mentioned this earlier, for the people, I know this sounds crazy, but that are working on the billing side in hospitals. They are overwhelmed, and they are boxed into like following rules and following the approaches and having to do coding. And they're actually, just like in hospital systems, you have on the clinician side, and I think it has a lot to do with, as you've mentioned earlier, the way there's like private equity taking over, and there's everything's focused on the bottom line. I think that some of that is driving, putting pressure on, nurses, we all know about that, and doctors, and them being able to attract those kinds of positions. Well, the same thing's happening on the billing side of things too. And so, yes, I think we can do things probably differently, but this has to do with, how we have a system where there's a different payer than the individual, and there has to be a system for keeping track of that, and there has to be, how much did they negotiate for the price. And so we have this absurd coding system that there's people who are experts in figuring that out and getting it right, but they're also overworked, and things change constantly for them. And so that's why you end up with these, billing errors. And again, I caution about making further investments in those systems that are taking money out of those clinician salaries and physician salaries and, the actual treatment. And I don't know what the answer is, but I just want to make sure we're looking at the full picture and not just thinking there's these evil billers out there that are sitting there trying to screw people. I don't think that's what's happening. I think that there's just systemic rules that they're following that we've built, and they're struggling.
I'm actually dealing with a billing error now.
Yeah.
From
And it's
that
frustrating.
Fall almost 2 years ago, because the wrong regional office was billed, and I don't know what happened. I'm like, I don't owe this. I already paid this. And, I made a phone call, and it's like, oh, it looks like they billed the Philadelphia office, and they should have billed the St. Paul office. So,
I want to bill them for the time it takes me to call them.
You think about the privilege. I'm on the phone all the time, but what if being able to make phone calls during business hours, and then how do you even know what to say?
Right, I know. And then you have to go call somebody else, and it's a lot. It becomes a full-time job, yes.
I think it's almost solved, he said ironically. AI is going to take care of all this. It's just going to be, Dave, you owe a king's ransom on your medical bill. By the way, when I asked about the coding, I didn't give credit where it was due. Marie on Zoom, thank you for prompting me about the coding. That wasn't my own cleverness. It was Marie posing a good question. I guess for Jennifer, internationally, other countries don't have medical debt like we do, and some of it's single payer, but this is America has distinguished itself in allowing our citizens to become mired in this stuff.
Yeah, aren't we lucky? I mean, other countries do it so much better, but we have a system that's hard to change. To make changes, I mean, we have employers who don't really want to be offering health insurance because it's expensive for them all to administrate. And, there's a big employer group in Indiana that are really pushing back on provider prices. And I think they're getting more engaged. But if they could drop offering coverage tomorrow, they all would, because it's such a headache for them to do this every year, to have annual open enrollment periods and to find affordable coverage for their employees. So unfortunately, that is unique to the U.S., and it's something we can change. But, going back to the coding issue, Medicare Advantage, and I know when you get to be near 65, you get to make a choice whether you go into Medicare Advantage or stay in traditional Medicare, where there's several academic and government reports that show that there's definitely overcoding by Medicare Advantage organizations to increase payments from the government to these private companies. And it's billions of dollars. And we have to get a handle on whether it's an intentional, looks like it's an intentional overcoding to make people look sicker so they get higher payments from the federal Medicare program. So it's not always, yeah, it's a lot of money that we could fix at the federal level if there's initiative to do that, and we should do that. But I have a constituent who had to go to the AG's office because there was a coding issue and it was $9,000, but they had to escalate it and deal with it when the person had lymphoma and was really sick, trying to deal with getting this medical expense removed and having to go to the AG, and the AG's office had to intervene with the hospital. Not everyone is going to do that, and it's a real burden on people who are really struggling. You're making the most vulnerable people who are very sick have to go through that process, and it takes months, sometimes years, to fix those coding mistakes.
We're getting toward the close, but Angela's show has people calling in with personal experience. But of course, because Allison was on the show, it's an example of you have experts. There's one more clip I'd like to play because it raises an interesting issue. If you could play clip 2, please.
There is a statute of limitation on the contract that created the debt in the first place. If it's more than 10 years old, but you're still being bothered by debt collectors, that's an Unfair Debt Collection Practices Act claim. For most people, what they need to know is education on how to deal with used to be just 2, now 3 credit reporting agencies. So debts, medical and otherwise, more than 10 years old ought to be expunged from credit reports.
Does that jibe with what your understanding of the system?
That was a lawyer who called in. She identified herself as a lawyer.
Well, I have a friend who married a person that then passed away 3 months after they got married, even though they were partners for a very long time. And after the person passed away, she was given a bill from 20 years earlier, and she paid it.
Wow.
She paid it.
And this happened in Minnesota. Mm-hmm.
Wow. But do you think she could have disputed it 20 years later?
I don't know.
Yeah, I wish we had the Attorney General, but I'll call.
Yeah.
I think it varies depending on,
Yeah.
from state to state.
Yeah.
I mean, so I don't know that there's so I don't have a good handle on where, but it does vary.
Super interesting. So again, Allison, you hope to be put out of business by reform? You'd be
Amen.
okay with that?
Yes, absolutely. I think I'm employable. I feel like
All right, that would a perfect way to end here. Quick, remember the online quiz for the swag? You know the routine. Sign up, and we have, it's sort of like the Oscars. We'll have PricewaterhouseCoopers be sure that the drawing for the 3 bags of swag is super fair, and we'll get back to you in 24 hours. I want to thank all of our panelists, and I know you do too. Allison Sesso, RIP Medical Debt. Jennifer Schultz, University of Minnesota, Duluth. The mysterious Keith Ellison, who had another commitment, Minnesota Attorney General. And your friend and my colleague, Angela Davis. Thank you so much.
Thanks for being here.
Marketplace Morning Report. You know when. It's on in the morning at 10 to the hour. There I am, turning up like a bad penny. My colleague Kai Risdal in the evening hour. Do you know that we've shown that some little babies start to salivate when they hear the Marketplace afternoon theme? Because it's the dinner hour. We do a lot of podcasts. I mean, many. I commend just a couple to you that come to mind. This is Uncomfortable, about difficult money issues, but also just difficult issues in people's lives, how we survive, about not just kvetching, as my grandmother would say, about climate change, but what are roads forward. and Million Bazillion, Personal Finance for Kids. It's a great show. Also, avail yourselves of all the wonderful resources that Minnesota Public Radio does and American Public Media does. And for those of you lucky enough to be actually here, I hope you think it's lucky enough, we're going to continue our conversation out in the front hall. We're not going to all just disappear if you have some questions that you don't think were answered. Everybody on Zoom, thank you very much and good night. And everybody here, let's have some fun in the next room. Good night.